A very good evening to all my dear students. How are you all? All set for your exams or still struggling? Of course, we keep studying till the end, isn't it? Right. Yes, a very good evening, all of you. Good evening. Oh, thank you so much for all your compliments. Right. So, before I start with the session, I really want to talk to you all. Can we please first listen? See, this session, first understand what are we going to do in the next 1 or 2 hours. So, this session is all about a very quick recap, which is going to be image based. Now, you must have realized that all my discussions are majority of the time image based only, isn't it? Yeah. So, because there is no sense of any discussion in ophthalmology if you don't have the images in front. It's easier, picture memory is always very important and it helps. Now, so this session, you have to understand that if you have attended the LRR series properly, you are going to enjoy it because I am expecting you to answer me more, right? So, more detailed discussion, go through your LRR. Here we are going for another quick recap. Now, secondly, one thing more which I want to tell you here is that the images, I could have taken more complicated images to discuss some image that you have never seen or so, but what is the aim of the session? The aim of the session is to pick up things that are asked in your exams, isn't it? So, that is the reason we are going to discuss and tried my best to put the images together which are very important for all the exams, for the exam point of view, right? Is it okay all of you? Shall we start? Jency, can we study now, beta? Right? Okay, we start now. Okay, so everybody is ready to answer. We start with the image 1. You have seen this image with me. Whenever you get an image like this, first thing is what it is. It's a ultrasound. Tell me all of you now, answer me. Is it ultrasound A scan or B scan? Is it ultrasound A scan or B scan? It is a USG B scan, we all know this. And what is this showing you? Many of you are answering. This is showing you the retina. We all know this is the lens. If I talk about this becomes the lens part, this is the vitreous and here is the retina. And we see this detached retina out here. Now, what is very important to understand, this is one of my favorite images no doubt, because it helps us to retain this very important point. Why these two images? Why not a single? It is showing you that in one posture of the head, the detached retina was like this. In the another posture of the head, the retina detached is like this, right? So, it is changed. So, why? Because the fluid, where is the fluid? Subretinal space, we all know retinal detachment is detachment of the RP from the neurosensory retina. So, this fluid in the subretinal space, this is the fluid which is mobile, shifting fluid. So, this is which type of RD? Yes, we are talking about. So, this is exam question. We will pick up cues only. So, we will talk about shifting fluid, and because we are looking at the shifting fluid, this is your exudative retinal detachment. Awesome. Many of you are answering. Very good. Clear hai? Okay. Now, another very quick few important things around this, which I would like to also revise with you. So, we are here to revise the cues. In which condition, answer me, you get Schaffer's sign. All of you have studied with me so many times. Where do you get Schaffer's sign? Quick, I'll wait for this answer. So, this is equally important. We also call it tobacco dust, isn't it? We call it tobacco dust. Awesome. So, this is mainly, all of you, this is mainly a feature of, okay, I'll wait for this. I'll put another question. Which is the most common type of retinal detachment? What is the most common type of RD? What will you answer? Most common type of RD is rhegmatogenous. isn't it? Regma is break. And Schaffer's sign is a feature of rhegmatogenous. One of you have already told me giant retinal tear. So, it is a feature of rhegmatogenous RD. Okay? So, these are some important questions that you have to keep in mind. What are the three types? Tractional, rhegmatogenous and exudative. Okay. Yes. So, if I focus talking only what is asked in the exam, this is it for the things around RD which I can remember. Yes, of course, configuration still you should know that traction, because of the traction band, is a concave configuration, whereas exudative is a convex configuration. And of course, exudative is very mobile, rhegmatogenous is undulating, but tractional is, what did we learn? It's a fixed RD. Okay. Chalo, we come to this. So, it's going to be a mix and match, then only we can have fun. So, LRR was topic wise, but this is not topic wise. Okay. So, then only we can enjoy the variety, isn't it? What do you see here? I want the answer first. Quickly, all of you. What is this? If I look at the first image, what do I see is that in this child, the left eye is convergent. And now when he is wearing his specs, this deviated eye has become straight. So, which type of squint is this? We all know we are talking about. Give me one diagnosis. If I ask you in one word, one diagnosis, one term. Bhai, happy baseball equipment, squint to theek hai. What is this? What is it actually showing you? How is it corrected by using the specs? So, the answer is, Dr. Light, can you complete the answer further? What type of accommodative squint? Yes, it is an accommodative. What type of accommodative? We should answer here, because it is corrected by specs, we can say it is a refractive type of accommodative squint. Am I clear to everyone? We have learned this very nicely, that accommodative squint can be refractive. Which refractive error? This is your exam question. So, which refractive error? It is hypermetropia. So, this has been framed like this for you all in the exam, that which refractive error is associated with esotropia, and it is hypermetropia in accommodative squints. And we all know which is the other type, non-refractive. What is non-refractive? Where the AC by A ratio, accommodative convergence by accommodation ratio is high, right? So, what is the normal range? Normal, it can range from 3 to 5, but hey, this ratio is 3 to 5 in a normal patient, normal person, where when it is high, even that can lead to accommodative squint. Even little bit of accommodation and the eye will converge. We remember this? Yeah. So, for refractive, we have corrected hypermetropia. For accommodative, what will you do? Either we can give pilocarpine. Why pilocarpine? Pilocarpine causes constriction, it causes ciliary contraction, and therefore helps in accommodation. So, the central impulse from accommodation is relaxed, and hence the convergence is corrected, isn't it? That means we answer like this, that in pilocarpine, so pilocarpine, Prakhar, revision is the key. Your brain is going to retain only if we keep revising, okay? And this is the reason we are having these sessions helping you all to revise. So, pilocarpine is taking care of the peripheral accommodation, and hence the central accommodation relaxes, or agar central accommodation is relaxing, in that case what is happening, that the eye will not converge. This is the case of the treatment for, and of course you can use near glasses to assist it, so that the patient, the aim is the child should not exert the accommodation, otherwise it is causing convergence. This is your non-refractive accommodative squint, you remember now, non-refractive type. And what was the third type? It is mixed type, where you have both the components, that is hypermetropia as well as you have this high AC by A ratio. So, this topic in squint is important, and this was the exam question, right? Am I missing any questions here? Nothing is tough, Pratiksha, nothing is tough. And whatever, just take one tip from me, whatever you find tough, just get after it till it becomes easy. ठीक है? पीछे पड़ जाओ बिल्कुल. ठीक है? If it is okay for us, it has to be okay for you as well. Right. So, we come to the next image. These two images are clear? What are the questions clear? Chalo batao. If I ask you in this slide, of course there are many images here. So if I have to ask you, okay, what is the diagnosis or what is the main term that you can give to this slide, I would say fluorescein angiography, isn't it? Yeah, fundus fluorescein angiography, isn't it? Okay, so let us take one by one. We talk about this. We all know this is a fluorescein angiography because the blood vessels here I can see the fluorescein, and what I see is I have taught you na, that when you are studying about fluorescein angiography, we will comment on hyperfluorescent and hypofluorescent findings. So here you can see all these hyperfluorescent dots. What are these? We all know microaneurysms. Sorry. So this is your exam question. Let's start solving here also. What we have to solve? Question number 1, what is the first sign of DR? First sign of diabetic retinopathy is microaneurysms. We have learned this, isn't it? Second question, in which layer are the these are all your exam questions. Which layer do you see this? We will answer it is nerve fiber layer, right? And please revise your ETDRS classification. If you've forgotten, go back to your LRR or your videos and try to see that, okay? So this is your ETDRS classification. You should know how the diabetic retinopathy is divided into very mild, where you only get microaneurysms, then mild, where you can get exudates and hemorrhage as well, then moderate as all pre-proliferative DR, right? And then we have after that pre-proliferative means you are getting more hypoxia, and therefore if you remember, I am quickly recapping with you that we get IRMA, intraretinal microvascular abnormalities, many cotton wool spots, large blot hemorrhages, isn't it? This is all moderate. Then what did we learn? Severe and very severe. And don't forget the 4:2:1 rule. This has been your exam question. Please revise this very quickly. Again, I am not writing, but I will speak it out. 4 quadrants पे if you get hemorrhages and exudates in all 4 quadrants, this is your again severe and PDR. Or you will say that looping and beading in 2 quadrants or IRMA in 1 quadrant. More than one feature of this 4:2:1 rule, then this is what? This is your very severe NPDR, right? So the message here is please revise this. Okay, we come back to the next. This is not even a fluorescein angiography. Seriously, what is ma'am saying? No, we are not using any fluorescein in this picture. Batao, all of you. What is this? Think and tell. I will wait. I will come to the next one. The next one, yes, this is a fluorescein, and what you can see is a flower petal pattern, and a flower petal pattern means this is a case of CME. So we are talking about cystoid macular edema. This is what is flower petal pattern. No, this is not bullseye. No. All of you, anybody can answer about this one? Is it a fluorescein angiography? I am saying no, it's not. So what is it? Think and tell. Okay, meantime, we come to this one. Again, I can see the leakage in a ink blot, enlarging ink blot fashion. An enlarging ink blot, this is what is. And what do you see here? What is this? This is your ring reflex can also be seen. This is your CSR, that is central serous retinopathy. Okay? Very good, Twinkle. This is, yes, many of you have answered. Yes, Lubna Kausar, very good. This is what is autofluorescence. Okay? So, there is no fluorescein because we are not using fluorescein here. Look at this. Can you see any dye in the blood vessel? No. But I can still see the fluorescent dots. So, this is lipofuscin. This is what a Stargardt's disease looks like, isn't it? So, this is not fluorescein angiography को कैसे लिखते हो? Fundus fluorescein angiography. Here what do you write? Fundus autofluorescence, AF. Okay. So, this is autofluorescence, and it's a feature of this fundus autofluorescence will be seen in cases of wherever you get a lipofuscin deposition, and in this case, this is a case of Stargardt's disease. ठीक है ना? Stargardt's disease, one more question here. Can you all remember? Don't forget, in angiography, what did we get in Stargardt's? All of you बताओगे? एंजियोग्राफी में क्या मिलता है स्टारगट्स में, बताओ. चलो ये भी you all will tell. In angiography, what do you get in Stargardt's disease? I'll wait for that. Let me revise a few things in CME and CSR, which is important. Again, it is asked in your exams, right? So, I'll just very quickly talk about it. So, when you say CME, CME is breaking of inner blood retinal barrier, right? This is one important exam question. It is the breaking of inner blood retinal barrier. Second important point, it can also happen when you take niacin, right? Third important point is already we have solved, that is flower petal pattern, isn't it? Okay. And of course, we have learned CME about Irwin gas syndrome, which is CME after cataract surgery. We will not forget that as well. And also one more question, that why is epinephrine not given in aphakic glaucoma? So, epinephrine is contraindicated, should not be given in aphakic glaucoma. Why? Because it can lead to again CME. In aphakic patients, this can lead to CME, right? So, I have just quickly discussed all the questions around CME, and of course, CSR you all know. Verbally I am going to discuss this very quickly. CSR is breaking of outer blood retinal barrier, isn't it? What else? We have learnt ring reflex, ink blot appearance, smokestack appearance. All this is asked in the exam. Okay? And of course, we will not forget, majority of the times the patient is a young male, and in acute cases it's a self-limiting disease. In chronic cases, we may have to go for photodynamic therapy, where the doses are half of what we give for age-related macular degeneration, isn't it? Very quickly, and of course, one more point, which is your exam question. Steroids are, I hope you're noting down, steroids are contraindicated in CSR. Don't forget that. Steroids aggravate CSR. Very good. I could see this. Sangeeta has answered. So, what is the fluorescein angiography finding in a Stargardt's disease? It is silent choroid. What we call dark choroid sign or silent choroid. So, Stargardt's disease is also the feature can be, you can see on angiography. What was dark choroid sign, you all remember, where you cannot see the choroidal blood vessels because of the deposition of the lipofuscin. So, that was dark choroid sign, right? Yes, very nice. So, this is all about, we come to the next image. Let's focus back, reboot. Now, this is the image in front of you. Of course, you know what I am showing you. I can see this, that you all are very sure this is cherry red spot, isn't it? Yeah. So, don't forget, you have to revise this important image here, cherry red spot. Cherry red spot, and these are attenuated arteries. Okay? The arteries are all attenuated. What else you are getting? Apart from that, so when you start describing an image, you should say it's a fundus picture where I can see the disc and the macula. So, I am looking at the central retina, isn't it? And which eye is this? This is the fundus picture of, I have taught you, this is right eye, isn't it? So, macula is always temporal to the disc. Okay. So, next we talk about is, and because we are you understand, and we are looking at the patient now, so the patient is standing opposite to me. So, you have to always think opposite in that term. So, this will become the right eye fundus. Now, you got it na? Chalo. ये अगर हमें पता है, then of course there is a lot of severe edema here which we can see. So, this is the case of CRAO, isn't it? So, this is what is central retinal artery occlusion. यही बताया ना आप लोग ने? Yes. Okay. Very good. So, you all are already answering. So, very quickly, verbally, we will learn this, revise this. What are the other causes of cherry red spot? How did I teach you? Cherry red spot, what are the causes? How will you learn? Number 1, trauma. Number 2, CRAO. Don't say it is the most common cause or not. I don't think anywhere it is termed that it is the most common cause of cherry red. But you have to just remember Berlin's edema, that is commotio retinae is one cause, CRAO is another cause, और तीसरा क्या बोलोगे? All the depositions, Tay-Sachs disease, Niemann-Pick, sialosis, send-off, ये सारा, right? So, these are the cause of cherry red spot, and Gaucher's also Gaucher's. This is debatable, so I am telling you. And GM1 gangliosidosis type 2. GM1 gangliosidosis type 2 में भी होता है cherry red spot. याद रहेगा? Okay, so this was about the questions. Another question from CRO. Another question is in front of you. What you see in this image? So this patient has got a central retinal artery occlusion, but he is not blind because of this artery. What is this artery? This is your cilioretinal artery, because this supplies almost the papillomacular bundle. So this cilioretinal artery, another question, is the branch of, it's a branch of short posterior ciliary artery, and because of this cilioretinal artery, this patient will retain this much of vision, padha hai na? And what is that called? Tunnel vision, right? So we will remember this. So this is showing you cilioretinal artery. One more question before I move further. The another question is, in CRAO, what is the critical time of treating the CRAO? What will you answer? The critical time is? When should you ideally treat the CRAO? What will you answer? Within 90 minutes. Otherwise, there can be irreversible damage to the retina. So the critical time is 90 minutes. Right? Okay. Before moving further to the next image, can you also tell me what are the causes of tunnel vision? Tunnel vision, for if I ask you the two drugs or medicines which can lead to tunnel vision, what will you answer? Don't forget vigabatrin. This has been your exam question. And second, of course, quinine, right? Yeah, what can be the other causes? We will also remember about gyrate atrophy, which is a choroidal dystrophy. Of course, late stage of retinitis pigmentosa, isn't it? Then occipital lobe lesion, keyhole vision, we have learned that, occipital lobe lesion, right? And of course, CRAO with cilioretinal artery. So these are all the causes of tunnel vision. ठीक है ना? Very good. Awesome. You all are answering well. Let's move to the next image. Refocus now. We have something else here. What do you see? What do you see here? You can almost read it as well. Can you see this child with the left eye ptosis, and when he is opening his eyes, the ptosis is corrected, isn't it? So this is what is your synkinetic ptosis. This synkinetic ptosis means there is an abnormal connection between the lateral pterygoid muscle and your LPS. LPS supplied by third nerve, lateral pterygoid, fifth nerve. Yes, this is your Marcus gun jaw winking phenomena. Okay, we'll remember this. This is that. Where else have you learned Marcus gun? Marcus gun pupil. Okay, bhulna nahi. So Marcus gun pupil, what you have learned? It is relative afferent pupillary defect. Okay. What is the one or two questions more on this topic? What is the most common type of ptosis? What will you answer? Most common type of ptosis? क्या पढ़ा है आपने? बताओ. So what is the most common type of ptosis? I think I'll wait for this. Another question is, what are the two main points we have learnt about congenital ptosis? So most common type of ptosis, nobody is answering to me. It is aponeurotic. Most common type of ptosis is actually aponeurotic, right? Yeah. And do you also remember in aponeurotic we have a high lid crease, isn't it? Yeah. So we come to this congenital ptosis. What are the 2 points we remember? Absent crease, because insertion on the skin is not there. Absence of lid crease. And remember lid lag on ptotic side. So if you ask the patient to look up, the ptotic eye is not going up. When you ask it to look down, even this is not going properly down, because LPS is not formed properly. Even the relaxation of the LPS is not good. है ना? Okay. So these 2 points, lid lag on ptotic side is one, and secondly absence of lid crease. And of course, we will also not forget from this topic blepharophimosis syndrome, isn't it? So revise this very well. We have learnt it nicely. We come to the next image here. What is this image showing you? Baseline, 2 eyes, central. When the patient is asked to look at the right, everything is fine, good. But when he is looking to his left, this is his right eye, this is his left eye. Oh, उल्टा है, ये right है, ये left है, I'm so sorry. हाँ ठीक ही तो बोला मैंने, right. Yeah. So this is the right and this is the left, yes. So when he is looking towards his left side, now what you see, no adduction here, and the abducting eye showing ataxic nystagmus, right? Yes, so this is a case of INO. Your answer should be, this is internuclear ophthalmoplegia. And what is internuclear ophthalmoplegia? You will answer to me, this is lesion of MLF, right? And if I ask you which side MLF is gone, so the side where there is defective adduction. So it is on this side, so this is a right MLF lesion. These are important images pertaining to your exams, so that is why we are discussing it again, right? So this has been asked so many times. Please be very thorough with this image, repeated in all exams. Okay, if you know this, time to very quickly revise. What did I teach you about horizontal gaze center? It is PPRF, and I am now going to revise it in my own style, which is an oversimplified diagram. So if you look at the oversimplified diagram here, agar this is a right PPRF, then what does it do? Of course, this is a supranuclear control. It is going to control the nucleus of the sixth nerve and finally the sixth nerve, which is innervating the LR. So the same side lateral rectus contracts. So this is your ipsilateral. What happens? So if I am looking to the right, I have explained you right PPRF will manage my right lateral. But what about my left medial? For my left medial, it is the other side, that is contralateral side. This is not going to directly innervate the medial rectus. For that it orders MLF. It is the left sided medial longitudinal fasciculus which is going to contract. It is going to send the message, right, to the here, so that it is your medial rectus which gets contracted. Same side medial rectus, isn't it? So ipsilateral is PPRF and LR. MLF and MR are also ipsilateral. What is contralateral? One side PPRF and the side MLF. Simple. And last point, the PPRF is maintained by contralateral FEF, frontal eye field. So it is the left sided frontal eye field which is managing this PPRF. So please learn this, and any lesion in this MLF is what is going to cause INO. Any lesion in PPRF, naturally, suppose right PPRF is gone, right LR is not working and left MR is not working because MLF से उसको message मिलता है. This is what is called right-sided horizontal gaze palsy. And if FEF is gone, it is contralateral horizontal gaze palsy. Okay, so revise all this. Good. And of course, 1.5 syndrome I have taught you is one side PPRF and the same side MLF is gone. So if right MLF is also gone, think with me, with this diagram it becomes very easy. If right PPRF is gone, no adduction here, no abduction here. And if MLF is also gone here, no adduction this side also. So this is 1 and this is half. So this is what is 1.5 syndrome, right? We have learned this where same side PPRF and MLF are gone. Okay. Yes, Devki, true. Okay, all of you, can you answer me one more thing before I move further? What is 8.5 syndrome? 8.5, quickly. Answer this and then I move further. Very good. 8.5 syndrome. Yes, 8.5 syndrome means it is your 7th nerve of the same side. Don't forget, 7th nerve palsy of the same side. Yes. We come to the next image here. Now tell me, what is the diagnosis? How do I start describing this image? I can see the optic disc. So should I leave with the diagnosis? Are you all going to answer me? What is the diagnosis here? Okay, okay, Devki. Sorry, I didn't see that. Yeah. You all are answering very well, very nice. Tell me about this one. What should I answer? What is it? Very good. So this is your cupping of disc and this is your glaucoma. What else can you see here? Apart from this cupping of disc, we all know cupping means increase of non-neuronal area, where the thinning of neuroretinal rim, where the nerve fibers have damaged, isn't it? We can see some amount of nasal shifting of vessels. We can see bending of the vessels, right? Double bending, what is that called? Bionetting sign. So slowly, of course, if it has been a more amount of cupping, it would have been more obvious what is bionetting. But yes, we can see the nasal shifting of vessels, isn't it? So, all of you, what are the things to remember? Where it is debatable is that when you are asked about what is the normal CD ratio, of course, normal CD ratio is documented as less than equal to 0.3, but we are going to be alert, or we start going for a workup of a patient only if the CD ratio is more than or equal to 0.6 or above. I know this is practically you have to learn 0.6 and above, right? Okay, very nice. So, this is clear to you, and of course, also do not forget your ISNT rule. Okay. So, we all know I is more than S is more than N is more than T. We are talking about the width of the neuroretinal rim. Let us take the, yeah. So, one more question here. What is the earliest field defect in open angle glaucoma? What will you answer? So, earliest field defect, please answer central or paracentral scotoma in Jerum's area. We have discussed this, okay, in detail. If you want, you can just go through your session. So, this is central or paracentral scotoma in Jerum's area. Very nice. Okay, we come to the next one. Acha, what is the last island of vision left behind? One more question here. Last visual field finding is which island of vision? It is the temporal island of vision. Devaki, what did you just say? Explain me why are you talking about centrocecal is a type of central scotoma, okay? At your level, you will just learn centrocecal, of course, can happen in any optic nerve lesion, and particularly we learn centrocecal in case of, you have learnt with me tobacco amblyopia, okay? So, it is just a type of, you all know, central scotoma where the scotoma is touching one side the optic disc and another side it is touching the blind spot, macular area. Hai na? So, one side blind spot, other side macula. This is what is centrocecal scotoma, and we will learn at our level, we will just learn about this, that it is mainly a feature of, and it is a type of central scotoma, can happen in any optic nerve lesion. ठीक है Devki? Right, very good. Yes, mainly it is a papillo PMB lesion, correct. Okay, we talk about this, and there was something more in my mind regarding I should be asking you. So, all of you, what is the, I hope you all are clear with these questions. I have discussed this earlier also. What is the choice, drug of choice for open angle? We answer prostaglandin analogs, latanoprost. Drug of choice for angle closure, again we start with latanoprost only. But if it is saying acute congestive glaucoma, we all know we talk about mannitol and acetazolamide. If they are asking you definitive treatment of angle closure glaucoma, then you should answer laser iodotomy. Hai na? Should we go for prophylactic iodotomy in the other eye? Yes, right. So, these are 4-5 questions I have just discussed. Keep in mind, I have done this, everything has been covered earlier as well. Okay. So, you will not forget this. And of course, what is the drug to open the angle? You want to constrict the pupil to open the angle, then we have to say pilocarpine. So, it's little twist here, just be alert about it. Yeah. So, why are we answering latanoprost as a choice of drug for angle closure? Because it is not mentioning which stage of angle closure glaucoma. And do not forget your classification according to natural history, right? Okay, we come to the next image. Everyone, this is a very important image for all exams. We all know what is the diagnosis here. What are we looking? Twinkle, what do you want to tell when you talk about uveoscleral? Yes, so this is your RP, retinitis pigmentosa. Most commonly, a first exam question, it is sporadic. We will not forget this, you know. Okay, what are these? Are the bony spicules. If you look at the image, we are looking at the central fundus and the mid periphery. We can see the spicules in the central fundus. At the disc, we see the pale waxy disc. This is the typical triad, isn't it? And attenuated arteries. So this is a case of retinitis pigmentosa. Please revise this, it's very, very important. Most commonly sporadic. If it is hereditary, we all know all three modes of inheritance are possible. What next question is on triad? We just learned. Another question is on field effects. So when you talk about field effects, we have made this diagram and learnt in early case. In a typical, if it is a typical disease, it will involve the mid periphery first, leading to ring scotoma in an early case, and later when it progresses, we have just learned we get a tunnel vision in the late case, isn't it? So we will remember tunnel vision in late stage, early case में ring scotoma, right? Any other question we have? Yes. What is the most common seismic association? We answer Usher's syndrome. Usher's is RP with deafness. Okay. Yeah, they have also asked you what is inverse RP. When it starts from the central, the pericentric RP is also called inverse because now it is the central vision which is involved first. है ना? तो हमें याद रहना चाहिए what is pericentric RP. Right. We all know no effective treatment, but there has been a question that you can go for supplement of docosahexaenoic acid. This has been a question, so we will not forget this. Right? It's a component in the rods and it is seen that sometimes it helps in slowing down the progress of the disease. But again, not 100% proved. Good. Right. We next talk about this image. All of you, what do you see here? So, what is this image? I can see on the slit lamp, this is your corneal slit. This is the corneal section which looks clear. And when in the lens, this looks clear, isn't it? This is all good. But here it is the nuclear cataract. Very good, right? So, nuclear cataract is mainly going to hamper, it's a central cataract. So, it's a cause of hemerotopia, that is day blindness. It's a central cataract. It can lead to difficulty in the vision in the daytime, number one. And number two, hundreds of times discussed is your second sight of what is your, that is improvement in near glasses. You know? So, when there is a nuclear cataract, what happens in an old patient? There is improvement in his presbyopic glasses. Why? We have learned this because the refractive index is increasing and this leads to myopic shift. Myopic shift means more power in the eye. More power means I need lesser power in my specs, isn't it? We have revised this so many times. This is another important exam question regarding nuclear cataract. Another thing regarding nuclear that we have to know is the most common, of course, it will mature, hypermature as hypermature nuclear sclerotic cataract. And in this case, what will be the most common complication? Most common complication, we are going to say subluxation of lens, isn't it? This is again your exam question. It is subluxation of lens. Right, guys? Okay. I just remember one more question. What is the most common cause of subluxation? Most common cause of subluxation is your subluxation ka most common cause bolo. What will you answer here? Trauma, trauma. Okay. We will say trauma. Acha, let me also remind you all that you have to revise the syndromes associated with subluxation. This verbally I will revise with you what is Marfan syndrome. You remember we made an M and we learned like this. In Marfan's, the ectopia lentis is superotemporal. In homocystinuria, just go the opposite, inferonasal. Right? Wheel Marchesani is downwards and forwards. Remember this. Okay. This is again asked. Can you tell me what are you now looking at? What is this slide, all of you? I see this as snowflake or snowstorm cataract, isn't it? Snowflake, snowstorm. Snowflake or snowstorm cataract is a feature, of course, of diabetes mellitus, right? Okay. More common in this morphology is more common in which type of diabetes? It is type 1 diabetes. Why are you getting cataract? We all know these are all exam questions. Sorbitol accumulation in the lens, and sorbitol is very hyperosmotic. Very good. Awesome. Everybody is revising well, isn't it? Yeah. And all of you, one more thing. Do you remember I taught you about frequent change of presbyopic glasses, frequent change of glasses? What were the causes of that? We will not answer diabetic cataract. I told you cause will be intermittent cataract, that is early cataract, late glaucoma, open angle glaucoma, and what was the next one? It was diabetes, not diabetic cataract. Why diabetes? Because if there is hyperglycemia, then in hyperglycemia there will be more swelling of the lens leading to myopic shift, and in hypoglycemia there will be hypermetropic shift. Is it clear? These are some important points to remember. Okay, I'll go to the next slide. Look at this one. We all know we are examining the retina. So, what is this? Direct ophthalmoscope. I am not even asking you because I know it's very easy. It was important to revise because it is asked almost every year, something or the other. So, when you say direct ophthalmoscope, the recent question is which eye of examiner, which eye of patient. I think you can see it here, same eye. In this case, right eye of the patient, right eye of the examiner. So, it is always the same eye is used so that we can observe in a crossed way, isn't it? And then it was asked, what will you tell the patient where she should or he should see? Not in the light, otherwise the pupil will constrict and it will be difficult to see the retina. So, what we say? It is mainly to be look straight, same eye and look straight. Yay, this was one question, same eye for examiner and the patient, right? Got it now? Okay, what was the next question? Everybody knows this. Magnification 15 times. At one point we can see 2 disc diameter. What is the type of image formed? It is virtual and erect. What do you see? Because the field is less, magnification is more, we are only seeing the central retina. Clear? Done? Okay. So, these are the important points regarding direct ophthalmoscopy. What is distant direct? When the same instrument is seen at a distance, we call it distant direct ophthalmoscopy. And in distant direct ophthalmoscopy, we are doing at what distance is exam question. We answer 25 centimeters. What are we seeing? We are seeing the media of the eye. What is media? All the structures on the way of the light ray till it reaches the retina. This is what is media. Yes, very good. Yeah, Devki, thank you so much for asking this. It is little out of the box. We'll talk about it little later. The feeling is always very good, but it takes a lot of time to even look at when you're in a first year of ophthalmology. It will take you almost more than of your first year to just be able to see the optic disc and the macula in your direct ophthalmoscope. Okay, yeah. Slowly we get trained how to look at it. Right. So anyway, we come back to indirect. The second one is indirect. What are the recent questions? Where is the image formed? So, in this case, what will you say? Where is the image formed? It is between the examiner and the lens. The image is formed here, okay, in the air. It is an aerial image which is formed here. And what is the type of image? We all know the type of images. So, this is one question. Second type of image, it is real and inverted. Real and inverted. Great, Devki, all the best. You're going to do very well. Definitely you'll get a chance. You just have to make up your mind, right? Just give your 100%, you'll get a chance. Nothing is impossible. It can be difficult, but it cannot be impossible. Okay, so real and inverted is a type of image We come to the next important thing. What is the next question? How much in one time you can see is 8 disc diameter. I hope you understand 8 disc diameter is 8 into 1.5 mm we are talking about. Disc diameter is 1.5 millimeters. Okay. So, what are we going to see? We are mainly seeing the periphery of the retina because the magnification is quite less. It is point into 3 or into 5. Okay. Do you all remember what I taught you? How do you calculate the magnification? Not asked in the exam, but just revise in your session. I am not going to take it because it is not asked to calculate. Okay. That was one extra point I have been teaching. We come to the next. Okay, you remember that concept ना? चलो बता ही देते हैं why to leave this point. I don't like it. So direct ophthalmoscope क्या पढ़ा था हमने? Power upon 4. So if your patient is emetropic, it is 60 diopters upon 4. So you are learning it as 15 times, isn't it? But you have to see if your patient is suppose minus 5. I taught you, isn't it? So minus 5 myopia means minus is myopia. Myopia is more power. So if I tell you my power is minus 5. What is the refractive power in my eye? It is 65, 60 plus 5. Please don't forget this concept. It is going to help you to solve all the numericals also around the astigmatism. And when we talk about the indirect, what did you learn? Indirect ophthalmoscopy, how do you calculate? It is power of eye and power of lens. Are good, I take this. One more question is there now, which is what is the power of lens? They have asked you the power of lens. I told you it can be used as plus 13 to plus 30. But majority of the times it is plus 20 and this is what you have to answer. Okay. And of course, power of eye will depend on the refractive error of the patient if he has any. Right. Okay. So, we now come to the next image. Very good. You all are answering well. Ye revise karo. This is what? Different type of astigmatism. I hope you know this very well. If you simple myopic means one axis is emetropic means simple myopic is something like this and one is myopic, है ना? Or simple hypermetropic, any axis could be this and one axis is this, it could be any axis. Possibility can be any. Compound means myopic. Compound myopic means both are minus but different numbers, minus 2, minus 3. Compound hypermetropic, it is plus 2 or plus, both are plus. It can be anything plus 2, plus 3, but both are plus, right? And when you say mix, we all know one axis is plus and one is minus, right? Okay. So, if you remember this, I hope you also remember about with the rule astigmatism is what? When vertical is more than horizontal. This is with the rule astigmatism. And what is against the rule? Opposite. Horizontal is more than vertical. So, this is your against the rule astigmatism. ठीक है? Okay. So, very quickly, because it is very important, very frequently asked in the exam, I am going to ask you this. I am just thinking anything in writing. We will quickly revise what is the type of astigmatism. Minus 3 diopter spherical, okay, and minus 2 diopter cylinder at 90 degree. How do you solve it? What is the type of astigmatism based on these two classifications? Batao. So, what you do here, we are going to just make 2 lines for the retinoscopy. Now, minus 3 is here also, minus 3 is here also. Then minus 2 at 90, axis is mentioned opposite. So, if it is at 90 it is written, that means power is at 180. So, what is the retinoscopic reading? Minus 3, minus 5. So, which power is more? Minus 5 means it is 65 diopters power, this is 63, this is more. So, this is against the rule compound myopic astigmatism, right. So, please revise this. Okay, we come to the next image here. So, next image if you see all three of, if I have to give one single name, I will talk about rings, isn't it. So, which ring is this? It is a copper deposition, golden brown ring at the limbus. All of you, we are talking about KF ring, Kayser-Fleischer ring. Okay, what are the points we have remembered in Kayser-Fleischer ring? Very, very important. Quickly tell me. This is copper deposition. Kahan pe? Descemet's membrane. It starts above and below and then becomes a circle. Next point, It will be seen in all patients of neurological complications of Wilson's disease. Of course, it's a feature of Wilson's disease. And only few patients, 65 to 67% of hepatic involvement. Not all patients, not all. These are some very, very important points regarding case of Fleischer. Another thing we have learned, is it reversible or irreversible? It is reversible. Even fading is sign of reversibility, and looking at it we can just see whether the drug is working or not, treatment is working or not. Come to the next one. This is what? Fleischer's ring. What have you learned for Fleischer's? It is iron deposition. Iron is deposited where? It is the iron is deposited at the base of the cone, and this is what is Fleischer's ring, at the base of the cone. Right. Which layer? It is epithelium. Right? Yeah. So, these are important points regarding. So, it is a feature of keratoconus. That was feature of calcosis, isn't it? Okay. We come to the third ring. We all know it's very simple. We are talking about imprint of iris pigment, which is Vossius ring. कहाँ मिलता है? Anterior capsule of lens. It is on the anterior capsule of lens. Right? It is seen in blunt trauma. These are the important points. So, if they ask you, if they give you this clinical picture, I hope you will be very, very clear. Okay. Come to this picture, all of you, so many times asked in the exam, please revise your legends of visual pathway. Whatever I have taught you should be revised very, very well. Okay, thoroughly. It is going to be asked. So, here what we see. Here what we are seeing, this is the left eye field and this is the right eye field, and both it is a right-sided homonymous hemianopia. Is there any doubt here? It is right-sided homonymous hemianopia, and most probably if it is an optic tract lesion, it will be which sided tract lesion? Answer me this. Very good, already answered by Sri Ram. It is a left optic tract lesion. Very good, Raghav. Left optic tract lesion. Hemioptic tract lesion? Acha, hemianopia you are trying to say. ठीक है. Left optic tract lesion. Very good. And do you also remember, let's quickly revise, what was the other thing asked in the exam for optic tract lesion? It is Wernicke's hemianopic pupil. Right? Wernicke's is the name we all know, where the pupil is also reacting half and half. This is Wernicke's hemianopic pupil. Okay. Give me one sec. Right. We come to the next thing. After this optic tract lesion, these are the 2 points to remember, and after these points, what else you have to know? Don't forget that when you talk about the optic tract lesion, that it is a incongruous. Okay? So, it is an incongruous lesion. What was incongruous and what was congruous? If you remember, I taught you posterior optic radiation lesions and visual cortex lesions are congruous, whereas tract lesion and anterior are incongruous. Incongruous means asymmetrical, that means the lesion is not in continuity. Congruous means the lesion is in continuity, it is a symmetrical defect. Okay? Yeah. So, that was about your this image. We come to the next image, very, very important again, asked in your exam. What is this? Tell me. So, this is what is your answer. Yes, very good. So, we are talking about leukocoria, right? And one question here, what is the most common cause of leukocoria? Most common cause of leukocoria, क्या बोलोगे? Congenital cataract. Please don't forget, it is not glaucoma. Common mistake, it is congenital cataract. Right. Then we talk about, of course, you should know all the DDs of leukocoria very quickly, verbally we can revise it. That of course retinoblastoma, and leaving aside retinoblastoma, all the other DDs of leukocoria, what do you collectively call? Pseudogliomas. We have learned this. We call it pseudogliomas. What are these? Congenital cataract, cyclitic membrane. Then we have talked about fungal endophthalmitis, central colobomas, central choroiditis, mainly by toxocariasis. We talked about central retinal detachments. What else? We also talked about central retinal dysplasias, Coats disease, PHPV. Okay? So, all these you have to remember, they are collectively called, yes, pseudogliomas. So, this was leuco is white, chorea is pupil. So, this is what is white pupil. Okay. So, once we know this DD, few more questions regarding and around retinoblastoma that we have to know. What is the most common mode of presentation? So, most common mode of presentation is your leukocoria, and then the next question is second most common mode. You will answer squint or strabismus. The next question is most common mode of spread. Now, this many of you keep asking, please answer through the optic nerve. Okay? Then they ask you most common non-ocular malignancy. क्या पढ़ा था? Osteosarcoma. Right? Will remember this? Yes. ठीक है? Okay. So, we come to next image. See, it's a variety I told you. What are you looking at? We are looking at grades of binocular single vision. Two dissimilar images, but you can see it as one like this. This is simultaneous perception grade 1. Almost similar images, but some difference when it fuses. This is grade 2 fusion, and grade 3 is when you know the depth, that is stereopsis depth perception. So, this is what are the 3 grades of binocular single vision. My next question, till what time it is formed? We will answer around 8 years. Right? Okay. And apart from these 2 questions, what else they ask you here? They have asked you about the tests related to BSV. Please again refer to your earlier session. I have talked about Wirth's 4-dot test. Please revise that. Okay. And one more that you should revise is your prism 4-diopter prism base out test. You remember? So, please revise these 2 tests, then you have totally revised your binocular single vision. Okay, we come to the next image. Yes, one of you were talking about this only. This has been a recent image of your exam. We will not forget. These are the true rosates. We call it Flexner Winter-Steiner. This is another question from retinoblastoma, isn't it? And the pseudo rosates are Homer Wright, and the third type is florates. So, we will not forget that. So, because there is a central lumen here, so this is your true rosates. This is central lumen, so this is true rosates. Okay. So, that was about this image. We come to the next image. What are you looking at? Can you give me the diagnosis here? What is this image? Yeah, central empty lumen, yes, twinkle, that's correct. Now, can you tell me what is this image? The next one. I can see if this is the right eye of the patient, left eye. When I am showing the light, maybe some sluggish light reflex, maybe it is absent, anything is possible regarding the light reflex. When I am showing some near stimulus here, near stimulus, this is leading to constriction, but again it is sluggish accommodation. And when why I am saying sluggish? Because when I am removing, even still it is constricted. So, it is a tonic pupil. This is your Holmes Addy pupil. So, please revise your abnormal pupillary reactions. So, this is what is Holmes Addy pupil or tonic pupil. Got it? Yeah. What is the next question they have asked you? Tonic pupil, I hope you remember, generally common in middle-aged females, showing majority of the times what is the position of the pupil? It is mid dilated, right? The patient is noticing on the daytime there is an isochoria, difference of the pupil size. Another question, how do you confirm? Don't forget, we give very low percentage of 0.125% of pilocarpine. Pilocarpine test, if it constricts, that means due to denervation hypersensitivity, it is responding to such low concentrations of pilocarpine. है ना? तो अब आप क्या बोलोगे? This is your Holmes-Addy pupil. Okay, so very quickly, what was your Argyll-Robertson pupil? We all remember? Light reflex absent, near reflex present. Acha, Holmes-Addy is lesion at the Holmes-Addy. This is lesion at the sympathetic chain, isn't it? Just give me 1 sec. There's some lag here. 1 minute, just 1 minute. I'll take very quickly one. So, yeah. So, what are we saying here? That this is your, where is the lesion in Holmes-Addy? Yes, I was talking about where is the lesion in the Holmes-Addy. क्या बोलोगे? It is ciliary ganglion. तो efferent pathway में lesion है. That means the lesion is in ciliary ganglion and short ciliary nerves, isn't it? Ciliary ganglion, short ciliary nerves. Okay, we come to the next. We will quickly revise what is Argyll-Robertson. Here the lesion is in the pretectal nucleus, and we all know that light reflex is absent and near reflex is present. Then what is the third abnormal pupillary reaction? Of course, we know relative afferent pupillary defect, isn't it? Which is diagnosed by swinging flashlight test. It is a first sign of optic nerve disease. What else you have to know? So, these 2 points, first sign. I think we have an image here of RAPD if I am not wrong. Can't remember. I'll just see. Okay, but let's run it. Swinging flashlight test. What else? We talk about TAPD, which is seen in optic atrophy, and of course we have to talk about Horner's syndrome. Will not forget this. Horner's is saying this is the lesion in the sympathetic chain. Did I say lesion in the yeah? Something wrong about this? Nahi na? ठीक है ना? So Holmes, I'll just revise. Holmes-Addy is lesion in the ciliary ganglion, short ciliary nerves. Then ARP is lesion in the pretectal. We talk about RAPD where there is a lesion in the optic nerve. TAPD again is due to optic atrophy, and lesion in the sympathetic chain is what is Horner's syndrome. ठीक है? If something was wrong, here is the correction. Okay. So Horner's we all know, this is very important, asked in the exam. Please revise it. It is mainly meiosis, ptosis, enophthalmos, and is it a true enophthalmos? No, it's an apparent enophthalmos. हम पढ़ चुके हैं. Meiosis, of course, due to uninhibited action of dilator pupillae, because sympathetic is supplying the dilator, because there is uninhibited action of iris sphincter. Dilator pupillae is gone due to sympathetic chain lesion, hence you get meiosis. What about ptosis? They have asked you so many times. I think it was recently asked in your NEET PG. Last NEET PG only, na? What is, why do you getting ptosis and Horner's? It is due to Muller's muscle. Muller's muscle is also called superior tarsal muscle. It is elevating only 2 mm of the lid, and this is the reason you are getting mild ptosis and Horner's. ठीक है? याद रहेगा? Yeah. So we will not forget that ptosis is due to Muller's. This has been a recent question. Very good. Chalo, next image. Again, you know, this is again repeated, so many times asked. We all know we are looking at, you can see the hairs coming out. This is a choristoma. This is mean nothing but limbal dermoid, right? Okay. We come to the next image. What is this showing you? Do you remember this? This is a complication of any intraocular surgery, but most commonly after trabeculectomy. First hint to you all. Most commonly after trabeculectomy, where aqueous is collected in the vitreous cavity, pushing the iris lens forward and leading to very shallow anterior chamber. Yes, I think now everybody knows. किसकी बात हो रही है? We are talking about malignant glaucoma. So, we are talking about malignant glaucoma. ठीक है? So, this is also called aqueous misdirection syndrome. And don't forget how we treat it is atropine, which dilates the ciliary ring and therefore breaks the cilio-lenticular blocks, right? Okay. And if atropine is not working, guys, all of you who have answered me atropine, if that is not working, what else? If atropine is not working, we can go for NDR, anterior hyaloidotomy, where you are making openings in the anterior hyaloid membrane. And if this is not working, we will have to go for pars plana vitrectomy, right? Important hai. One more important thing which has been asked, because it is the mydriatic which is being used to correct it, we also call it inverse glaucoma, isn't it? So, don't forget malignant glaucoma is also called inverse glaucoma, right? Okay, and what about, we have learned pigmentary glaucoma is called reverse glaucoma. Why? Because the iris is becoming more concave and rubbing on the suspensory ligament. Padha tha na? Please revise. This is also called reverse glaucoma. Good. We come to the next picture here. Very important again. What can you see? If I ask you to give diagnosis in one term, what will you answer? Yes, very good. Dr. Riluzol, yes, it is Krukenberg spindles can be seen in pigmentary glaucoma. Iris is concave and yes, very nice. Okay, we are back here with, this is the next slide, and we all know, if you look here, temporal is gone, temporal is gone. We are talking about bitemporal hemianopia. So, I think if one word, if I will say, these are chiasmal lesions. If it is a central lesion like this, then of course, what I am getting is bitemporal hemianopia. But we have also learned that sometimes the lesion is at this location, at the junction of chiasma and optic nerve. Then some fibers of the nerve are gone, leading to centroscotoma. And when fibers of chiasma is gone, we get superotemporal quadrantopia. Isn't it? We are getting superotemporal quadrantopia, right? So, why superotemporal quadrantopia? Explained here, because these are the inferonasal fibers which are detouring. Lesion is here. This is what is called anterior Wilbrand knee. Because of this Wilbrand's knee, which is affected, which is carrying inferonasal fibers. Therefore, the defect has to be just the opposite, superotemporal. ठीक है? Okay. Very good. Yes, pituitary adenomas will lead to bitemporal hemianopia, or you can also get the central chiasmal lesions, you can also get in craniopharyngiomas, and don't forget another cause, aneurysm circle of Willis, right. What is this? Which image is this one, all of you? Can you give me the diagnosis for this image? Tell me, what is it? Okay, so which procedure is this? What have you answered, all of you? Twinkle, capsulorhexis? No, Tanmay anise. This is a smile. What is smile? Small incision lenticule extraction. So, if you look here, this is a refractive surgery. We are using femto laser to cut a piece of stroma, and then we are removing it with a very small incision. So, it is a flapless surgery. We do not raise a flap. Okay. So, this is what is smile, that is small incision lenticule extraction. You remember this? It is a flapless surgery. Which laser we are using? It is femto laser. Okay, femto laser, 2 points we'll remember. What is the pulse duration? 10 to the power of minus 15 seconds, femtoseconds, isn't it? And second thing is, second you have to know is, what is the wavelength? 1054 nanometers. Normally when you are doing the refractive surgery like LASIK, so we are doing it with excimer. And this has been an exam question, that excimer, what is the wavelength? So, excimer wavelength is 193 nanometers. This is the wavelength of excimer. So, excimer is mainly used for other refractive surgeries like your LASIK. In LASIK, of course, you know we raise a flap. You have to revise all these basic refractive surgeries. I have taken the session. Okay? Quick? Okay, we come to the next one. Now tell me what is the image that you are looking at. These are optic radiation lesions, isn't it? So, this is your optic radiation lesion. Good, very good. Keratomyelitis. Myelitis is altering curvature of cornea. है ना देवकी? Yeah. Nice, nice. You all have answered me. This is your superior quadrantopia. Superior quadrantopia. है ना? Superior quadrantopia means inferior fibers are gone. So, it is also called pie in sky. This is important exam question. Please revise it. And this is seen in temporal lobe lesions. Isn't it? Temporal lobe lesion. So, these inferior fibers in the temporal lobe, they loop around. What is that called? Mayer's loop. Yeah. Come to this one. What is this? This is your pie in floor. Again, optic radiation fibers, some are passing through temporal, some are passing through parietal. If there is a damage in the parietal, any trauma in the parietal, superior fibers are gone, you get inferior quadrantopia. This is pie in floor. These are all not congruous, incongruous lesions. Posterior to that would be congruous. One of you had asked me this question. Okay? Yeah. Yeah, Baum's loop. Very good. Thank you for reminding Tanmay. So, this is mainly the superior fibers. They are called Baum's. It is BAUMS, Baum's loop. ठीक है? चलो, आगे बढ़ो. We come to this. What is this image? Can you all tell me? Very important. Again, asked in the exam. We all know this is your whirl-like deposition of the drug in a V-shaped manner. This is nothing but vortex keratopathy. Vortex keratopathy is also called cornea verticillata. Cornea verticillata. Okay, very quickly let's revise which anti-glaucoma drug? Nitasudil. Asked in the exam. It is important information. Of course, it is caused by chloroquine, then amiodarone. Very important is amiodarone, chloroquine, then tamoxifen, Fabry's disease, and what else? Indomethacin. These are the causes of vortex. And do you understand why there is a word like? Because it is actually only deposited in the epithelium, and when the epithelium is regenerating from the stem cells, it is in that pattern. So, the drug is also looking in that pattern. Okay? That is the reason you are getting a whirl-like deposition. Okay. And what about, this was your all and except exam question, I refer so many times. Chlorpromazine is mainly deposited in the endothelium, not here but in endothelium. ठीक? So, when you talk about the minimum stromal bed that should be left behind, that is only when you have raised a flap, you are talking about the stromal bed, na, Dr. Light. है ना, flap की thickness अलग, but then you are talking about stromal bed. So, we generally talk about this in relation to when you raise the flap. So, your answer is, it is in relation to LASIK. But anyway, we have to find out, in any way we are thinning the stroma, you have to know what is the minimum stromal thickness that is has to be left. This is not total stromal thickness. This is only stromal bed. The flap thickness is separate, right? Yeah. राघव क्या लिखा तुमने, मुझे समझ नहीं आया. फैब्रीज है, फैब्रीज, फेबर नहीं है. Yeah, I said it. All of you, are you writing? Did I not said this like this, Devki? Yeah. Thank you so much for appreciating and remembering my lines that I say, that all of you get ready with a paper and pen, because if you write by your own, you will retain more. However, you want to contradict this, but it is a fact. The more you draw, the more cues you make. In the last moment, just looking at the cues, just looking at your images, the ones that you have drawn yourself, understanding so much is going to retain much, much better. So, thank you for that. God bless. Okay, what is this? Next image. This is your adhesion of the bulbar and palpebral conjunctiva. This is what is called symblepharon. You know? And what we will learn, symblepharon can happen after any burns and chemical injuries, right? And of course, if you cut it, it can happen again. You have to go for mucosal grafting. Just remember that, right? Then ankyloplepharon was adhesion of the two lid margins. I have shown that in the earlier session. And this has also been a very important your exam question. The slide had come and they had asked you the diagnosis. You all know it's an extra row of eyelashes here. This is a case of dystichiasis, and dystichiasis again has to be immediately removed, right? Either you are epilating, but that is temporary. By diathermy or cryo, you can permanently damage the hair follicles so that it does not grow again and again, because it is rubbing on your cornea. Then what is trichiasis? It is misdirection of the eyelash due to scarring in the conjunctiva. And what is pseudotrichiasis? It is due to the entropion that you are getting this misdirection. Then we call it pseudotrichiasis. Okay? Okay. We next talk about is what is this image? Very important point, very important topic again asked in the exam. Okay, tell me. I can see this is a CT scan showing me the fusiform enlargement of the optic nerve on the left side, isn't it? So, if this is a fusiform enlargement of optic nerve, we are talking about optic nerve glioma. Very good. What are the points asked in the exam for optic nerve glioma? More common in NF1. Of course, this is mainly more common in female children, right? What else we will say? We have to know is most common pathological type. This is another exam question. The most common pathological is pilocytic astrocytoma. These are some important exam questions, right? And of course, fusiform enlargement, this image is important. And vice versa, I think we have learnt meningioma along with this. Quickly revise with me. Meningiomas are tubular enlargement with calcification, mainly in middle-aged females, more common in NF2, not in NF1. Easy to learn? Yeah. And mainly what you get there in pathology you have to learn is Samoma bodies. Optico-ciliary shunt and Samoma bodies, don't forget. Right. So, that was a quick revision. We come to the next slide. What is this? So, we know we are talking about thyroid disease. What I see, the lid retraction, I can see the sclera here, the sclera here. This is staring look. And what is the staring look known as? Cocker sign. So, this is a case of thyroid eye disease. We will revise it nicely, isn't it? Please revise thyroid eye disease. Thyroid eye disease, what is the pathogenesis? Is very, very important. Accumulation of GAG, autoimmunity against the orbital fibrocytes, fibroblasts, I mean to say, and enlargement of muscle, infiltration of inflammatory cells. If you remember the diagram we draw and we have learnt what is the pathogenesis and what are the things happening, enlargement of the muscle, infiltration of inflammatory cells, accumulation of glycosaminoglycans, and therefore the pressure in the orbit is more, pushing the eye out, causing proptosis. And when it is causing pressure on the nerve, this is going to lead to optic nerve compression and neuropathy. Remember that? This is important. Second thing that is important is about myopathy. What is the first muscle to be involved? We will remember it is inferior rectus. Last muscle to be involved we will learn as inferior oblique. Which part of the muscle is involved? It is mainly the belly of the muscle. And how do you differentiate from paralysis? We have learned post-duction test, isn't it? So, these are some important questions. And of course, another question on thyroid eye disease is about superior limbic keratoconjunctivitis, where only the superior limbus is congested. with mucus depositions. This is what is superior limbic keratoconjunctivitis, is a feature of again thyroid eye disease. So these are some important questions asked around TED. Please remember them. Dalrymple, it is lid retraction. Von Graffe, it is lid lag. You should know these. What is Stelvag signs? It is decreased frequency of blinking. Right. Come to the next. What is this image? Very good. This is segmental sheathing of the veins, venous sheathing, which is typically seen as candle wax drippings, and candle wax dripping has been exam question, we all know. So is it a peripheral retina or a central retina? I can't see the disc, I can't see the macula, so this is not peripheral. Okay? It is mainly, it is not central, because I can't see the disc and can't see the macula. This is not central. It's a periphery. At the periphery, we are seeing this venous sheathing, which is a sign of periphlebitis. This sheathing is segmental, typically seen in sarcoidosis. So we will remember this, sarcoidosis. Okay? Any other point for sarcoidosis we have to keep in mind? It can lead to interest. If you talk about ocular feature, you can quickly learn with my way, making a diagram. So we have learnt about interstitial keratitis, sarcoid nodules on the sclera and episclera. Remember? Then of course we have talked about one more thing is band-shaped keratopathy. Why do you get it? Because of hypercalcemia. Don't forget this, it's an exam question. And of course, granulomatous, another question. Rest what you are getting here is granulomatous pan uveitis. Very good. Nicely answered. Okay. We come to the next image. So the basic of action should be absolutely clear. That is the purpose for me to include this image, to let you know that action of muscles revise karna hai, the way I taught you. Vertical, horizontal. Horizontal mein you all know is simple. Vertical, remember, is and rad. Superiors are in tortors, recti are adductors. And when you talk about these yoke muscles, they are contralateral synergists. So what are yoke muscles? They are contralateral synergists. So if you are looking towards your right, it is right lateral, left medial. Towards your left, left lateral, right medial. What about this one? Dextro elevation. क्या पढ़ाया था? रिवाइज कर रहे हैं. Let's put in the box again. In an outward deviated eye, the action of elevation and depression is of recti. In an outward deviated eye, the deviated eye action of elevation and depression is of recti and vice versa. So it is dextro mein right eye is outward. So in outward deviated, this will be right. What are the muscles which elevate? It's a dextro elevation. पढ़ाया था ना? So superior rectus, inferior oblique. So what eye is outward? Right. So it is right superior rectus, left inferior oblique. Right? And here it will be right inferior rectus, left superior oblique. Left superior rectus, right inferior oblique. Right inferior rectus, left inferior rectus and right superior oblique. So whatever eye is outward deviated, it is the recti which will. This is again outward. So it is left superior rectus and right inferior oblique. I think I told this only, na? Yeah. Okay? So please be very clear about this concept. It is asked in the exam. Right. We come to the next question. Next slide. Can you tell me what is this? All of you quickly. Yes, very good. This is your aesthesiometer. It has been asked once. Aesthesiometer is mainly to measure the corneal sensation, right? And what is the mainly the commonest way of doing it is with a cotton wisp. Okay, can you tell me what are the causes of decreased corneal sensation? क्या पढ़ा था? Decreased corneal sensation. We will learn leprosy, diabetes, chronic corneal degenerative diseases like absolute glaucoma, phthisis bulbi. What else? Then we can talk about section of trigeminal nerve. So, we will remember, and of course, how can we forget viral keratoconjunctivitis. So, these are some of the causes of decreased corneal sensation. This we have to keep in mind. Okay, what is this next slide? Talk about this one. This is what? Give me the diagnosis, please. So, if I look here, I can see the haze in the cornea. There is a corneal edema. I can see hypopyon. Yes, and there is no fundal glow. वैसे तो you can't comment unless you are peeping in about the fundal glow. So, this is mainly a case of, we are talking about endophthalmitis. Please revise endophthalmitis. Very quickly I am taking it verbally. Early onset endophthalmitis. What is the most common cause? Staph epidermidis. Late onset, recently asked, propionobacterium. Acne, and second would be fungal, either of it. I think it was a recent question we were discussing about whether it is late onset or early onset, depending on what it says, isn't it? Recall session? Yeah. So, this is one thing, and secondly, they have asked you about the treatment of endophthalmitis. If it is hand movement or less, we go for pars plana vitrectomy. If it is the better vision, what is the choice of treatment? We will answer intravitreal antibiotic injections. What we give is ceftazidime, vancomycin, and very small doses of dexamethasone. So, I have taken this all in detail. Please revise it nicely. The causes can be asked, the management can be asked, and of course, you know how it presents with pain, redness, photophobia, blepharospasm, and very important point here is absent fundal glow, and there will be a lot of vitritis and exudates in the vitreous. That is very important, is vitreous exudates, isn't it? Yeah. Okay. So, most dangerous complication of after cataract surgery. We come to this image. All of you, what is this? Tell me. So, I can see hyphae here. Guess for you all. It's a dry, rough look. So, there is no hypopyon here, but if there was a hypopyon, it would be sterile or unsterile? Unsterile. Yes, we are talking about keratomycosis, right? Lot of questions on keratomycosis. Another question, what else you can get in keratomycosis is satellite nodules. Another exam question, satellite nodules. Very good. Okay, so they ask you what is the most common cause of fungal keratomycosis. Keratomycosis is fungal only. So, keratomycosis, what will you answer? Aspergillus fumigatus. What is the second best answer? Fusarium. Don't forget this. And if I ask you most common fungus infecting lids, it is Candida. Very good. And most common fungus causing endophthalmitis is again Candida. And most common fungus which is causing orbital cellulitis, mucormycosis. You have written all this in my earlier session, so I am not writing it. Very quickly revise this. ठीक है? Lids हो गया, endophthalmitis हो गया. In all this, there is Candida albicans, and for orbital cellulitis, I am again repeating, we will answer mucormycosis. Another question is, how do you stain? We all know we are talking about KOH smear, mainly KOH smear. Of course, Gomori is methamine silver stain, but KOH smear पे question आया है. And they have asked you about the drug of choice for keratomycosis, which is 5% natamycin should be your answer for drug of choice of keratomycosis. ठीक है? Question has been on unsterile. So, please don't forget this diagram which I always make. If this is the ulcer, these are the projecting hens hyphae. The hypopyon is unsterile. If you make diagrams, you will never forget. Satellite nodules. याद रहेगा? Yeah. So, all these are exam questions. Okay, we come to the next image. Tell me what is this? So, what I can see here is ultrasound B scan, and this B scan is showing me the ectasia which is happening posteriorly. This is what is posterior staphyloma, right? So we all know about the types of staphyloma. We have learned this diagram and learned here that it can either be anterior staphyloma is from the cornea, which you generally see in cases of pseudocorneas. Then that is sloughing corneal ulcer. We have also talked about at the limbus, generally peripheral ulcers can lead to, this is what is intercalary when it happens from the limbus. This is anterior staphyloma, this is intercalary, and when it is happening at the ciliary area, this is ciliary. This is equatorial staphyloma and comes finally the posterior. So, you are looking at the ultrasound B scan showing posterior. Exam question, cause pathological myopia, isn't it? Pathological myopia. Another exam question, most common type of staphyloma, most common type again is posterior staphyloma. Yes, very good. This was about your this image. We come to the next one. What are you seeing here? Can anyone give me the diagnosis for this image? I would like to leave this and go to the next. I would first like you all to answer this one. What is the diagnosis? What is this? Dhyan se dekh lo. Tell me what is this? Yeah. So this, no, these are not stria. These are prominent corneal nerves. Very well said. These are prominent corneal nerves. Now can you tell me where do you get a prominent corneal nerves? When the cornea is thin. So we are talking about keratoconus. Okay. Where there is no thickening of the nerves, it is thinning of the cornea. But what about if the prominent corneal nerves are due to thickening of the nerves? So we will revise that what are the causes of thickening of nerves. So thickening of nerves, you should not forget, is your leprosy again and NF1. These two are very important. Okay. Right. So we come to the next image. This is what we all know. We are talking about Maddox rod, which is a series of cylindrical lenses. So when you say Maddox rod, you are placing in front of patient's right eye. This is his left eye. So from the right eye, he is seeing a line now. Because the rods are placed horizontally, the line is vertical. From the left eye, he is seeing it as a dot. The image is formed on his left eye as a dot, right eye as a line. Now you ask the patient what can he see. So what can be the observation or the results? What are the three options? I am revising Maddox rod, please pay attention. If the patient says, yes, I can see the line passing through the spot, this is your orthophoria. So we are generally doing this test to diagnose what? We are doing this test to diagnose latent squint. Hai na? So which latent squint? Suppose the patient says the line is to my right and the spot is to my left. This is how the patient is seeing. Uske right side line hai, left side. So it is right of right. So this is uncrossed diplopia. So this is esophoria. You remember uncrossed in eso, and if he says line is left, spot is right, this becomes exophoria, right? Because exocrossed, when the line is generally formed on the right retina but is seen on the left side of the spot, it's a cross diplopia, isn't it? So this is a cross diplopia and this one is uncrossed diplopia. So please revise this. This is asked in the exam. And how have I made you all to learn about crossed and uncrossed? That how to learn, you have never to miss. Make a cross, make an arrow. What type of squint is this? Divergent. So cross diplopia is seen in exotropia or exophoria. It is seen in divergent squints. And vice versa, if you are making convergence, it is like this, which is uncrossed. So uncrossed is seen in ESO. So this is my way of making you all run. किसमें क्या मिलता है, ठीक है? Helps? Right. We come to the next image. I think one diagnosis we all know what it is. Can you talk about this? This is your heterochromia iridis. And what I can see is cataract as well. Most probably it's a posterior subcapsular cataract. What do you see here? We see Amsler's sign where there is a bleeding after paracentesis. What do you see here? These are stellate KPs, isn't it? So, what is the diagnosis? Stellate KPs with feathery ends, with heterochromia iridis. It's a heterochromic cyclitis. So, here our diagnosis is Fuchs heterochromic cyclitis. Let's remember that this is an atypical anterior uveitis. It's an atypical anterior uveitis. Right? So, please revise this. We come to the next image. So, here it's written also very simple. This patient, this is the right eye, this is the left eye I can see ptosis, and what else you can see? Down and out. The position of eye is down and out. So, it's a third nerve palsy. Okay, some important points. If there was a ptosis on both the sides, if there was a bilateral ptosis, if bilateral ptosis in such a patient, then what type of lesion is this? It's a nuclear lesion. You remember that? I've discussed this. Then it's a nuclear lesion. Okay? Yeah. What else? We also have to remember the one point that we have learnt earlier. What is medical and surgical third nerve palsy? This is the third nerve. Simple diagram. These are the pupillary fibers. Let's make it with some other color. This is your pupillary fibers, right? And so these pupillary fibers are supplied by pile blood vessels, right? And this core is supplied by vasa vasorum. So in case of diabetes, hypertension, this is involved. So this is what is called medical third nerve palsy, and in medical third nerve palsy, what do you get? Pupillary reactions will be normal because pupillary fibers are spared. But if there is any compression here, compressive lesion, isn't it? So this will be involving the pile blood vessels and the pupillary fibers are involved. And do you remember I also taught you that when the pupillary fibers are involved, initially there is constriction, and when all the fibers are damaged, there slowly will be the dilatation. So meiosis followed by mydriasis. Kya padha tha? This is what is seen in case of compressive lesions here, and this is what is called Hutchison's pupil. Meiosis followed by mydriasis, and this is what is called Hutchison's pupil. Then, right? Okay. So these are the important points around third nerve palsy we have to remember apart from the features, and revise all your 3, 4, 6 palsies. I have discussed it. Come on, what is this? Very simple image. So you can see cobblestone appearance. So cobblestone appearance is seen in So cobblestone appearance is of course seen in vernal keratoconjunctivitis, isn't it? So cobblestone in vernal keratoconjunctivitis. और क्या questions याद रखने हैं? Don't forget about shield ulcer. We all know what are microerosions with deposition of mucus. So one question they've asked you here is on shield ulcer. One question is when there is if suppose there is a pseudomembrane on this cobblestone appearance, we have learned this is what is called Maxwell-Lewin sign, right? Then we have to also remember Horner transverse spots, don't forget that. And what type of hypersensitivity is also exam question. It's a type 1 hypersensitivity reaction. Okay, we'll remember that. Okay, another thing that you should remember has been recently asked is about when you use a chronic use of contact lens sphere, that is going to lead to giant papillary conjunctivitis, isn't it? Where again the papilla are more than 1 millimeter in size, then you call it giant papillary conjunctivitis. It is due to overwear syndrome, where overwearing of generally soft contact lens. So all of you are wearing contact lenses. Few rules here: don't overwear, 4 to 5 hours a day is enough. Number 2, always wash your hand with soap and water once you are using it. Okay? And try to use disposable lenses, we all can afford that. then the risk of infections are minimized. Right. We come to the next. What is this image, all of you? Answer me here. What is this image? Okay, so Tanmay, this is not tono pen, but if you only answer tonometer, what is the means? I don't mean to ask that basic question here. I want to know which type of tonometer. Batao. So I think one of you have answered correctly. It is mainly we are talking about can you see it is over the lid? So this is what is called diaton tonometer. Diaton is transpalpebral. Can you tell me another test which is transpalpebral to see the intraocular pressures? Digital. Digital tonometry which you do just to have a quick idea is also transpalpebral. And what is the main use of this transpalpebral? Diaton का main use कहाँ है? This is mainly if the patient is using a keratoprosthesis. In that case, it is better to go for transpalpebral. So these points you should remember, and please revise your tonometers. Very important, isn't it? So which are, if you very quickly, if I have to talk about, so what are the non-contact tonometers? That is one question they ask you. You all know we are talking about pulse air, we are talking about pulse air and air puff, isn't it? Right. Then another question is tonometer, which is a choice in children. Now you in infants, you will answer tono pen as a first choice. I've taught you. And second can be Perkins, which is a handheld version. Gold standard, of course, is handheld version of Goldman. And gold standard for a measurement is still Goldman only. Right? We have learned this. In scarred and irregular corneas, again it is tono pen. Scarred, irregular, it is tono pen. So I want you all to quickly revise all this, right? So revise your tonometers. Okay, we come to this next image. Tell me, what is this image here? Everybody knows I'm talking about pterygium. So I know that you know, but this is an important topic. This is the message I want to give. Please revise it, all the questions here. First question, it is not inflammatory, it is mainly a degenerative disease. Next question, more common nasally. Again, it is elastotic, degeneration of the conjunctiva. What else? Is the definitive, which ultraviolet ray occurrence etiology? It is UVB rays. What else we have learned? How do you differentiate from pterygium from pseudopterygium? Pseudopterygium is nothing but a scar. पढ़ा था हमने glass rod test. If it passes easily, it is pseudopterygium because pseudopterygium is only attached at the apex. And if it is not able to pass, this is pterygium. What else we have learned? That what is the best way of preventing recurrence? We will answer autografting. And which is the best way of doing autografting? We will talk about perfect surgery, isn't it? That is pterygium extended resection followed by extended conjunctival transplantation. So please revise everything because this is a very, very frequently asked question. Okay? And do you all remember the iron deposition which can happen in front at the head? What do we call this? Stocker's line. यही बुलाते हैं ना? Stocker's line. Very good. Collagen cross-linking you generally go for in keratoconus. So what is this image? So this is your pinhole. We all know that. Please remember pinhole test. Revise it. First question, what is the size of pinhole? It can be 1 mm or 1.25 mm. Okay? In pinhole test, if the vision is improving, it means there is some refractive error, and if it is worsening, then either there is some central opacity like central cataracts, or it could be some macular disease, common sense, right? So these are the points we should know. And of course, what is this? We all know stenopic slit. We have learned the uses, stenopic slit कहाँ पढ़ा था? Stenopix Finchem's test. It can also be used to find the axis where you have to do an optical iridectomy, right? For optical iridectomy. So please revise this again, very important, pinhole test and Fincham, that is Stenopix slit. Okay. What is this? Can you all tell me what image is this? First and second, are they related or not? So Raghav, I think I've explained this, that when you're doing a Finchem's test, in an immature cataract, you are looking at halos, then while passing the slit across the pupil, you see these halos are breaking and making. मतलब कुछ टूट रहे हैं, continuous नहीं दिख रहा. If it is due to acute congestive glaucoma, even through passing the slit, the halos don't break. So that is the main difference. ठीक है Raghav? No, Dr. J, what is the diagnosis? Look at this patient. He is opening his eyes, looks everything fine. When he closes his eyes, left eye is closed, but right eye cannot be closed. Isn't it? Yes, Twinkle, this is a case of leg ophthalmos. Leg ophthalmos means it is inability to close the eye. So, which is the muscle which closes the eye? It is orbicularis oculi. Isn't it? So, it is orbicularis oculi. And which is supplied by 7th nerve. So, in 7th nerve palsy, you can get facial nerve palsy, you get leg ophthalmos. And is it related? The second image is related? Anybody? Oh, I'm sorry, Raghav. So sometimes these things happen when we are not sitting side by side, है ना? In front of each other. Then these things will happen. Don't mind. Is it related? What is it related? Yes, very good, Tanmay, Bani. Yes. So because there is a leg ophthalmos, this patient is having exposure keratitis, isn't it? And exposure keratitis is happening because, can you see this? Lower part में ही ज़्यादा आपको changes दिख रहे हैं because it is mainly this part which is exposed. What do you call this? We call it, this whole thing, condition, answer me this also. What do we call this? No, this is the exposure keratopathy which is happening, exposure keratitis happening due to leg ophthalmos is also called, we call it neuroparalytic keratitis. Remember, I have taught you this, neuroparalytic keratitis, because it is due to the 7th nerve palsy. Okay? And what about, at this point we will learn what is neurotrophic keratitis. Neurotrophic, it is due to 5th nerve involvement. जब 5th nerve चली गई, now no release of neuropeptides. No release of neuropeptides means health of epithelium is compromised and therefore you are getting a keratitis. ठीक है? Epithelial health is compromised leading to keratitis, and this keratitis is called, what did I say? This keratitis is called your neurotrophic keratitis. So you should know the difference, neurotrophic, neuroparalytic. Yeah, take it. What is this image, all of you? What are you seeing here is an opacity against the black background of the maxillary sinus. This is what is called, we all know this, teardrop sign. Please don't forget, this topic is very important. And what am I talking about? Blowout fractures. So it is a feature of blowout fracture. Acha, Suno, you all remember I taught you all about oculocardiac reflex, that how pulling of the muscle can actually lead to bradycardia and sometimes also called cardiac arrest. And if you remember, you've got a question on this, that this generally happens during strabismus surgery when there is a pull on the muscle. Ye pata hai na? So another thing, another point, don't forget, even in these fractures sometimes, or in road traffic accidents mainly, okay, what you can get is muscle pull or muscle injury, and this can also incite a oculocardiac reflex. So oculocardiac reflex that you have learnt can be seen in this or it can be seen in squint surgery. So, these two places you will remember with me. Okay? Sangeeta, what are you talking about? 368 is mainly not oculocardiac. That was vestibular reflex. I am talking about oculocardiac. We are not talking about doll's eye reflex. Okay? Okay. Now tell me, what is this? What do you call this multiple flame shaped hemorrhage around the disc? I can see the hemorrhages. I can also see the cotton wool spots. What do we call this? This is your splash sauce appearance. Splash sauce appearance is a feature of, हमने पढ़ा हुआ है, central retinal vein occlusion. Now splash sauce appearance के बाद, what is another question on this? I think I have discussed so many times, 100-day glaucoma. What did we learn? It is nothing but neovascular glaucoma. If you remember your common pathogenesis of retinitis proliferans, which I taught you, hypoxia, release of hypoxia will first cause increased capillary permeability. That is going to lead to leakage. That leakage is leading to hemorrhage, exudates and edema, and then more leakage is going to cause, when more hypoxia happens, it aggravates, it leads to release of chemotactic factors that causes neovascularization. Neovascularization we have learnt NVD, NVG, NVE, NVD and NVE, and because of this neovascularization, these blood vessels, they will grow. Along with that, fibrous tissue is growing, and there are 3 blinding complications: vitreous hemorrhage, tractional retinal detachment, neovascular glaucoma. I hope you remember it. Please revise from your previous session. So, this neovascular glaucoma in CRVO is seen to happen after 100 days. Okay? So, these two questions we can remember? Yeah, very good. Splash sauce appearance is mainly a CRVO, and this pizza pie या sauce and cheese retinopathy is seen in CMV retinitis. It is mainly a necrosis. You will see in a retinitis, सबसे important है, splash sauce is around the optic disc, whereas this is mainly at the periphery of the retina, more at the mid periphery and periphery. And the way it travels along the arteries is called brush fire appearance. Okay, so that is a feature of CMV retinitis. ठीक है तन्मय? Okay. Rohit, what did you answer for pan-retinal photocoagulation? Were you talking about the treatment or something? Yeah, if it is ischemic type, we will go for PRP in ischemic CRVO. ठीक है? Yeah. चलो, next image क्या है अपने पास? Okay, so what is this? We all know we are talking about dacryocystography. And what do you see here? There is a blockage here and distension and mucocele formation. And here there is a, as you can see, this is lacrimal stone. We have learned this, or lacrimal stone. This is a space occupying, this is lacrimal stone. So, this is DCG. What are the things that you have to know more about in this chapter? We have to know about the test, and of course, what is scintillography? Scintillography is when you are using radioactive. So, when you have to study the tear flow in physiological condition, it is scintillography. If they ask you what is the investigation of choice for catching functional or lacrimal punk failure, then again we should answer scintillography. Right? Okay. We next talk about is this image. So, everybody knows here there is disinsertion of iris from its root, isn't it? And what is this called? This is your iridodialysis. It can happen after blunt trauma. और क्या पढ़ा है? Image pupil कैसी है? You can see it is not round, it is a D-shaped pupil. So, we will answer D-shaped pupil. Okay? Yeah. We come to the next. Okay, so this was there, the image is there. Tubular enlargement with calcification. We are talking about, we have revised this already. This is what is your meningiomas. No? So, we are talking about meningioma, right? Okay. Next is, I think now one of you were answering this. Can you see we are holding the capsule and tearing it in a circle? Yes. So, this is what is your capsulorhexis. See here. Okay. Can you see this capsule here? So, this is your capsulorhexis. They have asked you a question like this. They have given you the slide and asked you what is the step which is going on in this image. Which step of the cataract surgery? So, that was your question. So, you should know what is capsulorhexis. This is your continuous curvilinear capsulorhexis type of capsulotomy. Very good. Nice. Okay. Okay. And this is again important, you all know. They can ask you, what are you looking at? Everybody knows. We are talking about Bitot spot. So, please revise your xerophthalmia. Bitot spot is more common on which side? This is one question. We all know it is more common temporally. Right? Earliest feature of xerophthalmia. If they ask you like this, earliest feature, what you will answer? It is nyctalopia, night blindness. Please revise the causes of nyctalopia I have taught you. Night blindness. What else? I'll go with the important one. How to differentiate between primary signs and secondary signs of xerophthalmia. Have I told you this? So, when you say primary means it is only in xerophthalmia and no other conditions. Secondary means you can see in other conditions. So, secondary signs are XN, XS, XF. Okay. We have other causes of night blindness, other causes of corneal scarring and other causes of white spotted fundus, that is xerophthalmic fundus in this case. Okay. So, these are secondary signs and these are primary signs or rest of the signs. Please revise your WHO grading. Another question is on treatment. I hope we all know if the patient is more than 1 year, you are giving injectable vitamin A 1 lakh international unit. है ना? On 0, 1 and 14 नहीं भूलना है, very important. If your patient is less than 1 year, we just half the dose. And if you are giving oral, you just double in each case. Oral is always double of injectable. Just remember this much. Take? Okay. Yes. What are you looking at here? What is this image? All of you? Batao. So, what is this image? What oil drop? Shan, what oil drop? Everybody is written oil drop. First, tell me the first image. What is this? It is not oil drop. It is not oil drop. It is oil globule reflex. Can you see the first one? Can we see this anterior lenticonus? And here what you get in retroillumination when you are looking in the slit lamp, you are getting oil globule reflex. So, it is not a drop. Okay? So, this was in relation to anterior lenticonus. What are the other questions they have asked you here? More common in males. And another one, that this is mainly seen in Alport syndrome. A for A, Alport syndrome is familial hemorrhagic nephritis. It is also seen in Waardenburg syndrome. Very good. Yes. So, we remember this, and posterior lenticonus, Loeys syndrome. Right. And of course, when you talk about oil droplet, let's revise. Oil droplet reflex and oil droplet cataract. We all know oil droplet cataract, so many times we have learned this, is galactosemia. Galactosemia is also can be a reversible cataract, and oil droplet reflex is a feature of keratoconus. Now, this is seen in under slit lamp. Here we see it by distant direct ophthalmoscopy. Just remember this much. Okay? Yeah. So, this is asked, it is important. Okay, so we come to this one. What is this image all about? I want the diagnosis of the whole slide. What is the condition where all these three images will fit? Think about it. I think I've discussed this. If you have learnt or heard my earlier sessions, you can answer this. Batao. So this one I'll wait. Yes, very good. Awesome. No Tanmay. Bunny is right. Yes, these are all. Shan is also right. Many of you are right here. Dr. Riluzol. I'm so sorry to pronounce, but I don't know. So these are, many of you have answered correctly. Which drug side effect, Prakhar? It is chloroquine only. ठीक है? It is chloroquine only. So chloroquine के side effects में what you have learned? Posterior. Can you see it is a posterior subcapsular? Are you convinced? Can you see this corneal section? Look here. This is the cornea slit. The light is going everything from here to here. The lens is clear, but not here. This is not clear, है ना? So it's a posterior subcapsular cataract, right? Then you talk about this one. This you know is vortex keratopathy. We all know this. This is vortex keratopathy. And then look at this one. This is your bullseye maculopathy. Can you see the alternate areas of hyper and hypo? Take. So yes, these are all side effects of chloroquine. So our answer will be side effect of chloroquine. Yes. ठीक है? Okay. So these are some of the important images and the topics that I have taught you, that around this you have to revise the topics, don't forget. And as you know, as always, whenever I end the session, we always end with some thought for the day and something to take away, है ना? So what is the takeaway for today? This is most important. Let's read it together. We all have the power to overcome any problem. Okay? So let's ignite that never giving up spirit. So these are mainly the words of the great philosopher, that is Daisaku Ikeda. So what he says, we all have the power to overcome any problem. So let's ignite that never giving up spirit of still I am not discouraged. So write it in front of your study table. Still I am not discouraged. And keep fighting and dash forward. You have to dash forward. Okay? Right? Yes. So thank you so much. I hope you enjoyed the session. Revise your LRR also before the exams nicely. Okay. Keep studying harder than yesterday. You should be better than your yesterday. You should run your own race. You may feel low sometimes. Go back to the thought for the day. Go back to this line. Still, I'm not discouraged. Right? Okay. Any other questions? Thank you, Shan. Thank you for appreciating the session. This is so rewarding. You feel so satisfied that the hard work is appreciated. Yes, this PDF will be shared. Don't worry. Okay, so I end here. Thank you. Thank you so much. Stay blessed and keep smiling.